Welcome to a comprehensive overview of anti-MuSK antibody myasthenia gravis. This video will delve into the intricacies of this fascinating and often challenging autoimmune neuromuscular disorder. We'll explore its causes, how it affects the body, its diagnosis, and current treatment strategies. Join us as we unravel the complexities of anti-MuSK myasthenia gravis. The root cause of anti-MuSK myasthenia gravis lies within our own immune system. It's an autoimmune disorder, meaning the body's defense mechanisms mistakenly attack healthy tissues. In this case, the target is muscle-specific kinase, or MuSK, a crucial protein located at the neuromuscular junction. We don't fully understand what triggers this autoimmune response in the first place, but genetic predisposition and environmental factors are thought to play a role in its development. Let's understand how this disease disrupts the normal functioning of the neuromuscular junction. Normally, when a nerve impulse reaches a muscle, it triggers the release of acetylcholine, a neurotransmitter. Acetylcholine binds to acetylcholine receptors on the muscle cell, initiating muscle contraction. In anti-MuSK myasthenia gravis, antibodies bind to MuSK, interfering with its role in clustering acetylcholine receptors. This reduces the number of functional receptors available at the neuromuscular junction, impairing the transmission of nerve impulses and leading to muscle weakness. Because MuSK is involved in the stabilization and maintenance of these receptors, the antibodies against MuSK can severely impact signal transmission. Anti-MuSK myasthenia gravis is considered a relatively rare condition, accounting for a smaller percentage of all myasthenia gravis cases compared to the more common acetylcholine receptor antibody-positive form. It is observed more frequently in women than in men, and while it can occur at any age, it often presents in the younger to middle-aged adult population. Precise prevalence rates can vary depending on geographic location and study methodology, but it is estimated to be considerably less prevalent than the anti-HR form. The hallmark of anti-MuSK myasthenia gravis is fluctuating muscle weakness that worsens with activity and improves with rest. However, the distribution of weakness often differs from traditional myasthenia gravis. Individuals with anti-MuSK antibodies frequently experience prominent involvement of the bulbar muscles, leading to difficulties with speech, swallowing, and chewing. Neck muscle weakness is also common, causing head drop. Limb weakness is present but can be more proximal, affecting the shoulders and hips. Double vision and droopy eyelids may also occur, but are typically less prominent features compared to the acetylcholine receptor antibody-positive form. Respiratory muscle weakness, while less common than bulbar symptoms, is a serious complication that can lead to breathing difficulties and requires immediate medical attention. Diagnosing anti-MuSK myasthenia gravis involves a comprehensive approach. The process usually starts with a thorough neurological examination to assess muscle strength, reflexes, and cranial nerve function. Blood tests are essential to detect the presence of anti-MuSK antibodies. However, it's important to note that some individuals with clinical features suggestive of myasthenia gravis may test negative for both anti-MuSK and anti-HR antibodies. These individuals are classified as seronegative. Electrophysiological studies, such as repetitive nerve stimulation and single-fiber electromyography, can help confirm the diagnosis by demonstrating impaired neuromuscular transmission. A tensilon test, involving the administration of edrophonium chloride, may also be performed, although it tends to be less reliable in anti-MuSK cases compared to the acetylcholine receptor antibody-positive form. MRI of the thymus is not required. While myasthenia gravis can be broadly categorized based on antibody status, such as anti-MuSK positive, anti-HR positive, and seronegative, anti-MuSK myasthenia gravis itself doesn't have widely recognized distinct subtypes. However, the severity and specific symptoms can vary significantly between individuals. Some patients may experience predominantly bulbar symptoms, while others may have more generalized weakness. Disease progression can also vary, with some individuals experiencing periods of remission and exacerbation, while others have a more chronic and progressive course. Treatment for anti-MuSK myasthenia gravis aims to improve muscle strength and reduce the severity of symptoms. Immunosuppressive therapies are the mainstay of treatment, often including corticosteroids like prednisone. Steroid-sparing agents, such as azathioprine, mycophenolate mofetil, or rituximab, are frequently used to minimize the long-term side effects of corticosteroids. Intravenous immunoglobulin (IVIG) and plasma exchange (PLET) are effective in providing short-term symptom relief during exacerbations or as a bridge to longer-acting immunosuppressants. Cholinesterase inhibitors, which are commonly used in acetylcholine receptor antibody-positive myasthenia gravis, are generally less effective and may even worsen symptoms in some anti-MuSK patients. Careful monitoring and management of potential complications, such as respiratory failure, are crucial. Physical therapy and occupational therapy can also help individuals maintain muscle strength and function. Currently, there are no proven preventative measures to completely eliminate the risk of developing anti-MuSK myasthenia gravis. Since the exact trigger for the autoimmune response is unknown, targeted prevention strategies are challenging. However, maintaining a healthy lifestyle, managing stress, and avoiding potential environmental triggers may contribute to overall well-being and potentially reduce the risk in susceptible individuals. The prognosis for individuals with anti-MuSK myasthenia gravis can vary. With appropriate treatment and management, many individuals can achieve significant symptom improvement and maintain a good quality of life. However, some individuals may experience more severe or refractory disease, requiring more aggressive immunosuppressive therapies. Recent research is focused on understanding the specific mechanisms underlying anti-MuSK antibody production and developing more targeted therapies to selectively deplete or neutralize these antibodies. Clinical trials are also exploring the potential of novel immunosuppressants and immunomodulatory agents to improve outcomes and reduce the burden of this challenging condition. The medical community is constantly striving to find new and better ways to diagnose, treat, and manage anti-MuSK myasthenia gravis, bringing hope for improved outcomes in the future.